I would like to introduce Ms Bridget Egan, who is going to introduce the Carmichael Lecturer. Thanks.
Hello, good afternoon, everybody. Today, the 33rd Carmichael Lecture entitled Leading Change, Aligning Clinician Science and Politics will be delivered by Ms Mary Harney, former Tánaiste and Minister for Health. Ms Harney is a former Irish politician who was Tánaiste for 10 years and for 17 years served as Minister in various departments in environmental protection, enterprise, trade and employment, science and technology and health. She was the first woman Tánaiste and the longest serving woman as a cabinet minister in Ireland. Ms Harney was also the first woman to lead a political party in Ireland. Having retired from politics in 2011, she now engages in business consultancy and is a director in healthcare and in technology companies. She acts as a policy advisor to several organisations, mainly in healthcare, and is the independent chair of the Public Interest Committee of KPMG. Ms Harney is the former Chancellor of the University of Limerick, and she currently serves as chair of the Amber Research Centre in Trinity College Dublin. So we'd now like to call on Ms Harney to deliver the 33rd Carmichael Lecture.
Thank you very much, and it's a great pleasure to be here. And I suppose I could say it's better to see you here than maybe in some of your workplaces. And that's not personal to you. It's good not to be a patient most of the time. When I received the invitation from your President, President McNamara, I first noted that it was the 13th of February and it was a Friday. And I thought, that's an interesting date, and it's the day before Valentine's Day, of course. But I was actually daunted by the task of delivering a lecture when I looked at the people that had gone before me from such a diverse and thoughtful backgrounds. I think I'm the second only politician to deliver this lecture, the other being the late Seamus Mallon, who was a great friend of mine, and himself and John Hume owed so much by this country for the courage they displayed as constitutional politicians at a very difficult time in this country. But I don't take the honour lightly. It's a great honour, and thank you very much, President McNamara, for bestowing this honour on me. I hadn't heard of the late Michael Carmichael, I have to be honest, but obviously with the help of Dr. Google, I've been able to note that he was an advocate, an educator. He had an unwavering commitment to public good and public service, and he's a very fitting person to have this honour in native each year. And this, I think, is the 33rd year, although he lived in the 16th century, I think 17 something. And I'm delighted that the tradition is continuing. Today I'm going to speak about the alignment of science, medicine and politics for better patient care. And it's a conversation I know many of you lead in your everyday life. I was very interested in the last conversation about surgical clinical governance. I think it's fantastic that you're dwelling so much time. I think the document was in process for almost 2 years with a wide variety of people involved. And I'd like to compliment David Moore, whom I do know, and his team for presenting that document. And I was very interested in the comments from Michael Cairn about the private sector. Essentially, my experience is obviously in the public sector, although I am a fan of private healthcare. I don't think patients care who funds healthcare. What they care about is the quality of the healthcare they receive. And unfortunately, my great plan for co-location got chopped because of the financial crisis that hit the country, although it did have other enemies as well who believe in the ideology of the state must do everything. In medicine, there's much to celebrate. We live longer, new therapies constantly emerge, and the human misery that is illness is countered in more ways than ever before. But as progress unfolds, there's an anti-scientific surge. Rational policy making and the politics that underpin it are challenged by populism and special interests. There's nothing new in this. What is concerning, however, is the velocity of misinformation and the scale and power of an openly anti-rational politics. This is a moment of inflection in human history, and that is the challenge we must step up to and we must meet. In health, there's a lot at stake. I start by saying that scientists, doctors, and politicians have a vocation. When science, clinicians, and politicians align in the public good and share an evidence-based analysis, great progress can be achieved. It is usual to talk of that progress in terms of cohorts and large numbers of people. But although illness can spread among populations, being sick is not a communal activity. It's debilitating and sometimes deadly. It can be long-lasting and life-changing. It is a deeply emotional issue because it is highly personal. Empirical science and rational policy must always be married with effective politics and public support. It is not enough to do the right thing. Public policy must resonate emotionally as well as scientifically. Explaining the facts is a necessary start, but persuasion is never simply a scientific exercise. The world has changed a lot since I was Minister of Health 15 years ago. Thanks to advances in medicine, much more is possible. But costs have risen too, as treatments have become more complex. Today, the Irish public healthcare system spends 29 billion. It was 13 billion when I left health in 2011. That's an enormous increase, and it's 77% of what's spent in this country on health each year, the remaining being from private health insurance and some out-of-pocket expenses. Our population is ageing, which means we need more resources to treat more people. In so many ways, these are the positive challenges as we seek to deliver what is possible. Less positive, however, is an accelerating scepticism about science, medicine, and politics. Healthy scepticism seems to be, on occasion, tripping over into irrational phobia. This underlines the responsibility of those who take on the vocation of medicine, science, and politics. There is so much at stake. It is essential to understand the challenges that each of these different spheres have to endure. Strong evidence that informs good policy is destined to be academic unless it is supported by principled politics in the wider sense, including in the medical community, public administration, and public life. The reason for stepping up and delivering are compelling. Each one of those reasons is the health of patients who are sick and need care. At the beginning of this century, cancer care in Ireland delivered poor outcomes compared to what was possible. Working together, relying on clear evidence, and having the benefit of strong clinical leadership changed all that. It is no longer played out as inter-county football, where there are winners and losers in each county. Instead, outcomes were prioritised, cancer care was improved, and the index of human misery was reduced. My experience as Minister for Health in the years 2004 to 2011 reinforced my belief that health service reform and clinical service reorganisation depends on understanding the relationship between evidence, the responsiveness of the health system, and political decision-making. It is the synergy, not the siloing, of these interdependent parts that delivers change. There should be mutual understanding and a shared mission, always. Alignment is critical in a complex system of interlocking influencers. The real issue is not their independence, rather it is the risk that one is misunderstood, underestimated, or assumed to be sufficient. Progress requires that each is recognised for what it contributes to patient outcomes and that their independence is acknowledged from the outset. Scientific or organisational evidence is often the starting point for arguments about reform. It can point to outcomes achieved in systems where specialist teams, higher volumes, clear pathways, or new therapies are available. Evidence can also show the risks associated with fragmentation or low-volume practice. However, evidence alone cannot guarantee improvement. It is often not sufficient to persuade vested interests or indeed genuine patient concerns. the argument must be made in the public domain in order to succeed. Political decision-making shapes the environment in which reform happens. It determines whether the system has the authority, the resources, and the mandate to implement evidence-based changes. In clinical service reform, political decisions set priorities and protect designated services from dilution. They support investment in infrastructure and the workforce, and they hold organisations accountable for delivering agreed models of care. Political leadership must also withstand public pressure, regional sensitivities, and short-term demands. Without political support and endurance, even well-designed reforms can stall before they mature. Those pressures were always intense in Ireland, and they have certainly not lessened since I left politics. The critical difference between action and aspiration is politics. Of itself, it is seldom sufficient. Political success needs effective administrative systems. All those component parts need evidence that is the basis for good decision-making. A culture of innovation is shaped by many practical factors, including leadership, training, governance, facilities, IT systems, scheduling, and so on. So too is the ability of hospitals and primary care to coordinate with each other. Talk of reform often underestimates these practical realities. In practice, the ability to optimise expertise and capacity determines whether evidence-based care can be delivered and whether reform can be sustained over time. When evidence is cited without reference to organisational responsiveness, reform efforts can create bottlenecks and generate instability in the very services they're trying to improve. Reform requires change, but change does not always deliver reform. The interaction between these elements matters because clinical outcomes reflect systemic performance rather than isolated actions. When evidence aligns with realistic, responsive organisations and receives political endorsement, improvements occur. When any one of these is poorly understood or treated as optional, reform becomes fragile. Leadership at each level, clinical and political, ensures change generates trust, creates commitment, and binds together diverse groups in a shared understanding for better care. And evidence-based leadership did deliver a successful new approach to cancer care in Ireland. The evolution of cancer in Ireland from 2007 bears mentioning here. The late Dr. Donal Hollywood was appointed as the Director of Reforming Cancer Services for the Midland Health Board in 1997, in addition to his clinical practice in St James's Hospital and in the Midlands itself. The Health Board, against his strong advice, decided that cancer services would be divided between the 3 acute hospitals in the area in order to satisfy local political and, yes, clinical sensitivities. The interests of patients were certainly relegated. Dr. Hollywood was later a great supporter of the cancer reform programme. A report of the expert group on cancer care in Ireland led to the National Cancer Strategy in 2006. A central part of this was his recommendation of a model of 8 specialist cancer centres with multidisciplinary teams, and a move away from a situation where 32 hospitals were delivering, in most cases, very small volumes of complex cancer care. In the year before, 1 hospital performed 1 cancer surgery, for example. This strategy was endorsed by the government, and the National Cancer Control Programme was initiated in 2007 to implement this new structure on a national basis. To translate aspiration into action, strong and credible leadership was required. Dr. Tom Keane, Dublin-born and UCD educated, was internationally acknowledged for his transformation of cancer services in British Columbia. He agreed to accept the position as director of the programme. He and his team were given firm assurance of full political support. He was assisted by clinical leaders in each of the 8 centres. His unwavering commitment to the reform programme and his standing within the clinical community drove delivery of fundamental change locally and nationally. Complex cancer surgery, beginning with breast cancer, and multidisciplinary decision-making were consolidated into 8 centres from 2007 onwards. Predictably, this was not achieved without opposition, both clinical and political. Perception of local bias had to be dealt with, and the government, for example, lost the support of its only 2 Dáil deputies from Sligo. But we stood firm. It took time and persuasion to gather broad support for the change. Protest marches were organised countrywide. All opposition parties in the Dáil opposed the reform and promised to reverse it in office. Thankfully, that didn't happen, and instead progress was made. And I'd like to salute some of the members of your organisation who played a leading role here. I see Professor Kern in front of us, Professor Niall Higgins, I've seen here, another wonderful man, Arnie Hill, I don't see him here, and many, many other people played a lead. Oh, sorry, he obviously is here, beg your pardon. There was a time when we always noticed you, Arnie. My apologies. That is embarrassing. So we delivered progress. I also want to acknowledge my friend Thomas Lynch and his wife Mona, because Thomas was very involved in different aspects, not breast cancer obviously, but different aspects of cancer care. As the model took hold, outcomes began to improve. For example, the 5-year survival rate for rectal cancer increased from 66% to 73.5% from those diagnosed in 2003 to 2007 to those diagnosed 2008 to 2012. And breast cancer survival improved by 15% from 1994 to 2015. Ultimately, it was evidence that was the most powerful persuader. But progress would never have been achieved without the commitment under pressure and mutual support of doctors such as the people I've mentioned, administrators and politicians. In 2022, 2 Lancet papers assessed international trends in cancer survival. These studies noted that Ireland's gains in cancer survival were closely associated with the regionalisation of services and the consolidation of specialist care. The findings situated Ireland within a group of countries that implemented a national cancer control programme. This was consistent with international evidence linking centralisation with improved outcomes and survival. These gains in complex cancer treatment and survival rates cannot be taken for granted in the future. New pressures, including population, ageing, and local service issues inevitably come to the fore. The budgetary constraints on health systems can often direct the focus away from excellence in care. Nonetheless, the evidence for a multidisciplinary approach based on higher volume remains key to the improvement of survival rates. The example of British Columbia is again pertinent for a different reason. The gains that Dr. Tom Keane and Susan O'Reilly's team achieved over 2 decades gradually eroded. Both have now been appointed as advisors to the province's drive to recover the gains in cancer survival rates. Momentum must always be protected and propelled forward, or it will be lost. The experience with HPV immunisation in Ireland is another important example of aligning evidence, politics and clinical programmes. The HPV immunisation programme was evidently the right thing to do scientifically. The case was made for the long-term public health benefits of the vaccine, especially its potential to reduce cervical cancer and other HPV-related diseases. The decision to proceed was informed by a health technology assessment process. This provided robust evidence recommending the introduction of the vaccine for girls aged 12 to 13 before they became sexually active. This is when the vaccine would be of most benefit. The government made the decision to launch the programme against the background of an economic crash. The global financial crisis put immense pressure on public spending, particularly on healthcare. Questions were asked as to whether introducing the vaccine was feasible at the time. The initial HTA had assumed the cost of €100 per vaccine. It was decided to go to tender and delayed the implementation by a year. The process yielded a price of about a quarter of the original. So beginning in September 2010, we chose to vaccinate the first-year secondary school girls instead of primary school girls as originally considered. The vaccinated cohort was the same group that would have been vaccinated the previous year. Despite public commentary claiming that the delay might worsen the outcomes, the evidence shows the public health impact was preserved. The programme now contributes to Ireland's progress towards the WHO cervical cancer elimination targets. This was a clear example of balancing immediate fiscal realities against the greater good of public health, backed by the scientific evidence. However, the challenge of implementing such a programme nowadays are not simply financial. In fact, the social and political challenges are far more significant. There is less trust in healthcare systems worldwide. The growing threat of misinformation and disinformation present formidable obstacles to a population-based prevention programme like vaccination. In the early years of the programme, uptake was high, with more than 80% of the target group receiving the vaccine. Then, despite numerous studies confirming the safety and efficacy of the HPV vaccine, false claims about safety proliferated, particularly through social media, and the vaccine uptake dropped to below 50%. With the help of strong communication from doctors and the HSE, together with the advocacy of courageous women, vaccination rates have now improved and gone beyond 80%. The challenges the programme faced and the effective response made to them show that while it is wise to be worried about misinformation and disinformation, worrying doesn't deliver results. What does deliver are evidence-based facts that are carried forward into the public conversation through the channels and media that people use. Effective health reform is inseparable from informed and persuasive public information. The synergy of science, politics, and persuasive public information was especially evident during the COVID-19 pandemic. It was an extraordinary challenge that was dealt with effectively, notwithstanding the unfortunate death toll in Ireland and elsewhere. The pandemic presented the worldwide community with the task of identifying the characteristics of the virus and the pathways and modes of spread. Many differing views were expressed before certainty was established. Public health advice relied on best judgments of protective measures. As information became more solid and appropriate interventions became clearer, and this ensured that the advice could be framed in a way that would be implemented by the system and understood by the government and the public. Based on this public health advice, the government introduced major income support measures that aligned social protection with public health priorities. These measures supported high compliance and contributed to strong levels of public acceptance and trust in Ireland. The alignment between evidence-based public health, income protection, and political support is a clear example of how the rapid mobilisation of resources can both reinforce health outcomes and social solidarity during a crisis. At the same time, the pharma industry across the world engaged in an amazing endeavour to develop effective vaccines with unprecedented speed and extraordinary cooperation. Regulatory authorities in Europe and the US then used emergency measures to assess and approve the vaccines. The vaccination programme in Ireland from December 2020 achieved impressive population uptake, reaching over 97% in older age groups. This contributed to reducing ICU pressure and lower mortality in subsequent years. We live in a moment characterised by growing uncertainty about the future. There is indeed so much to be concerned about. The response to every challenge, however, is calm and considered action. The real threat we face is not the prospect of catastrophe, it is the danger of catastrophising. Irish politics is now more disparate than before. No, it's not really more desperate, it's more disparate. Certainly, there's a greater variety of people in there. And most of the time they don't know how to dress for the National Parliament. Anyway, I wouldn't like to not know who the surgeon was when I go into the theatre. Old patterns of localism are as strong as ever, however, in Ireland. Sharply increased parliamentary turnover makes cohesion harder to achieve. It is necessary to understand the challenges before you face them, but faced they must be. In relation to cancer, HPV and COVID, to name just 3 examples, we delivered successfully. We need not be overwhelmed or disheartened if we align and work together. In healthcare, solid evidence is the essential information for leadership, but without clinical and political leaders, little can happen. As we face the future, it is worth reflecting on the past and on the extraordinary progress we have made. In just over the 100th anniversary of the history of this state, how the physical body experiences human life has been transformed. Plumbing, penicillin, and the contraceptive pill created a new reality about how life is lived that was unimaginable in previous human history. We take it for granted, but in Ireland it's only a reality available for the last 70 years. Pain and squalor are no longer accepted norms, and now there is the immediate horizon of extraordinary medical developments. At times, however, there is intense frustration and frequent failure in politics, medicine and science. Where there is power, there is always squabbling, and where there is bravery, there's always a risk of failure. In a world beset with problems, it's imperative to remember that we have never had such potential. This is especially true in healthcare. Inertia and the status quo are the no man's land between success and failure. Alignment between scientists, doctors, administrators and politicians leads to better outcomes for patients. It is natural to worry, but there is no excuse for being disheartened. We are surrounded by an unprecedented abundance of potential solutions. If you try in isolation, you will almost certainly fail. But if you build alliances, if you stand firm, if you explain clearly and have solid evidence and try again, great change is possible. Great change has been successfully delivered and it will be again. Our shared purpose in healthcare is ultimately not about science, administration or politics. It is about the better care of the sick. Caring for the sick is first and last a vocation. It is a fundamental human virtue that is honoured in every society and every age. What lies between us and better healthcare is our capacity to align, to build alliances and to work together. In the face of these challenges that we all confront on a daily basis, many of us often lose heart, but we mustn't. Many of the challenges come from within our system, but when we act together, when scientific evidence, clinical leadership, and administrative skill are effectively led politically, we can win. Ladies and gentlemen, we have the good fortune to live in an age of unprecedented plenty in terms of what is possible. It is our responsibility to do what's right with what we have. Evidence and courage do always prevail. Thank you.
I'd like to thank Ms Harney for her wonderful lecture, and I'm now going to ask Professor McNamara to come forward to present the Carmichael Medal.